Well, yeah, I think in general, is this on? No.
I think it's on.
Is it on? Oh, okay. In general, I think, yeah, anticoagulating patients with cirrhosis makes my skin crawl. I mean, in general, that's why I have been more watchful, waiting. Gosh, are we really going to anticoagulate this patient? It depends on their comorbidities, their support, their compliance. But, you know, in more and more studies, we're seeing favorable outcomes. And I think if you're careful about assessing their bleeding risk ahead of time, particularly varices. So in my clinic, what I do is I set them up, if I have time, I set them up for endoscopy right away, and I band varices aggressively until obliterated or small. And then I start anticoagulation. That's in the setting of no ischemic compromise to the bowel. But I'd be curious to see what others in the room do.
Good.
Yeah, it's just as Todd said, I really don't like anticoagulating people with varices. But, you know, the thing about it is that the risk factors, if you look at the risk factors for bleeding of varices, a high INR doesn't predict your varices are going to bleed. It's just that if you bleed worse. So if a patient actually, so what I would do is actually scope them. If they have high-risk stigmata, I would band them. And then I actually would anticoagulate them. But I actually stay away from anticoagulation unless the superior mesenteric vein is involved, or if they actually have an acute thrombosis and developing evidence of liver failure. In that situation, I would recommend doing it. But I actually try to stay away from doing it.
For the purposes of capturing your questions, I'm going to give you the mic.
Oh, thank you. Why do Tavor patients require multiple transfusions? I mean, Tavor, I understand you're cracking their chest open, you're putting them on a bypass pump, but Tavor is like doing an extended catheterization is essentially what you're doing, right?
Yeah, my expertise here is limited as a hepatologist, but I guess the point of the data was to show that there were less transfusions with Tavor. I guess your question is, why are there any at all? I think a lot of these patients are anemic at baseline. I think there is some valve-related hemolysis, regardless of the device. Yeah, that would be my presumption.
Hi. For the periodontal care, some of those studies seem to be in patients with MELD scores of 10 or less. How do you guys approach patients that have significantly higher MELD scores, in particular patients with significant coagulopathies? You know, we frequently get these letters from dentists asking for quote-unquote liver clearance. Their INRs are like 3. How do you approach that in your practice?
Yeah. So the study was less sick patients, you're right. So the coagulopathy, I think it's a moving target, and I think all of us, if you poll, will have a slightly different answer. I'll give you my answer. I'm not as interested in the INR. I don't think that really pertains much unless they have DIC. If they're in the hospital, they're bleeding from their nose, they're bleeding from venipuncture sites, those patients, they have a clinical coagulopathy, and the INR is perhaps useful. But I think in the outpatient stable cirrhotic, the INR really is useful as a synthetic dysfunction tool and very little more. Fibrinogen levels may have more of a role in coagulation, and we don't measure those routinely as outpatients. And then the platelets are different. I do think there is a clinical bleeding risk with the more thrombocytopenic somebody is. And I don't know where the number is, to be honest. Some people use 50, 30, 70. But I think if you send somebody with severe thrombocytopenia to the dentist, you have to have some plan in place. And it can be transfusions at the time. It can be TPO agonists, which are approved for this indication now in cirrhotic patients for short-term treatment prior to the planned procedure. And they have clearly been shown to increase platelet counts. Whether we're preventing bleeding, I think, is a separate question.
So yeah, I think this is definitely an important role to do this, especially in the low MELD patients. One of the worst experiences I've ever had at Stanford was when I got there. I had to go scope somebody in the OR because they were pulling 22 teeth at the same time. And basically the guy died. He died a couple of days later because he just couldn't stop the bleeding. To die from oral bleeding, I mean, it was one of the worst things I've ever seen. And I always look back and I figure, what could he have done differently? I mean, you leave it to the oral maxillofacial surgeon, because dentists don't do this kind of stuff, to look at the preoperative risk of doing this thing. And I think, again, with the TPO agents and so on, but like I always look back and I wonder if we like use TEG more appropriately to figure out how to, this patient went into primary fibrinolysis and we just couldn't stop him from bleeding. They were suturing the gums and everything. So I don't think you should take this lightly. People think just go in there and take it out, because these guys, I mean, they're pulling out more than 10 teeth eventually. And in patients with liver failure, it's a high risk thing. So I think if the dentist could find more conservative measures, which I try to encourage them rather than taking out all the teeth, that's what I try to do. And if they get a liver transplant, then they can actually go for, whatever they need after that.
One of the issues that I have at our institution is to get the interventional radiologist to do a paracentesis, especially large volume paracentesis, and they absolutely refuse to touch the patient unless we normalize their INR, which is almost impossible to do. We're pouring fresh frozen plasma into these patients to normalize it, even though going all the way back to probably even late 60s or early 70s, it's been proven that if you do a midline tap, the likelihood of a bleed, if you stick the needle in the midline, is very minimal, but they refuse to do it. What's your experience? I just haven't been able to convince these guys that just go ahead and do it, because it's not going to correct.
I think they're just finding an excuse.
You think so? You might be right.
We're lucky enough at our center, our radiologists, I think, are pretty progressive in the thinking here. That our policy is if we say this is a stable outpatient cirrhotic on the order, they don't even look at the coags or platelets. It's basically, we just trust them and they'll do it. I would ask that your interventional radiologist to look at their own literature. There's actually good guidelines in JVIR, some publications there. So in their own literature showing that platelet count hasn't been able to predict bleeding complications, or INR, I think more so, doesn't predict bleeding complications. And eventually, if you do enough of these, you will have a bleeding complication, but it doesn't matter what the INR or platelet is. And I think as long as the IR doc has the backup of the physician ordering the study. Now, if you send somebody who's septic, critically ill with bleeding coagulopathy, clinical coagulopathy, that's different. And you could probably postpone an elective tap or do a bedside diagnostic tap there.
On a question on the TAVR patients, especially the increased death rate in the ones that had TAVR versus a surgical approach. Well, what was the etiology of the cirrhosis in those patients, and were any of the cirrhotics, the cirrhosis in some patients related to the valvular heart disease itself, or was it a mixed bag, or did they not discuss the etiology?
I went to that presentation. I don't remember them feeling that there was a congestive hepatopathy component. They didn't have a lot of details on the patients. They had no details as to how they died, at least at the presentation I went to. As far as the makeup, I think it was a pretty standard makeup of cirrhotic patients, alcohol, viral, NASH. I don't think there were any real surprises there. But it was surprising to me how the Tavor patients, there must have been something I suspected that was at the clinician's discretion or the surgeon's discretion, that this patient's a good surgical candidate versus I'm not doing surgery for this one. I'm going to do a very new procedure where I don't have to cut them open. And I'm just imagining that group looked worse, and it just wasn't reflected in their baseline scores that they used.
I'm going to jump in with a question for you, Glenn. You mentioned the components of the SALT score for acute alcoholic liver disease and transplant. And in reviewing those, including at the meeting and in your presentation, those are the components that we at CPMC, for example, use when we don't transplant within 6 months. So my question is, has anyone looked at that score, which I think was developed for alcoholic hepatitis, but has anyone looked at that score to just bring in more consistency in all liver disease, all alcoholic liver disease, What about 8 months? I mean, we don't use that at CPMC, but I'm now curious about it. Is there any talk of just implementing that in everyone?
So I guess what we're alluding to is like any patient, any alcoholic, no matter how far out they are, whether or not we should be applying this. This whole issue of transplanting patients with alcoholic liver disease before 6 months, I differ from a lot of people at Stanford in how I look at this, and I'll just say that openly. I mean, they have patients who are MELD of 32, who have chronic alcoholic liver disease, who drank 5 months ago, and you have somebody with a MELD score of 32 who drank last week, and you're actually treating both of them as the same in terms of prioritization for liver transplant. I think that's a very unfair thing. And I think the one thing that as a transplant hepatologist that I try to do, and is what I was taught, is try to be fair to everybody. And I still think we don't have a fair way of doing this still, of allocating these organs to these patients. In terms of trying to predict, using a score to predict, because at the end of the day, right, what you really care about is who's going to drink after transplant. People try to make this an issue about mortality, right? Oh, his MELD score is 35, his Marjorie score is 38, he's going to die if he doesn't get a transplant. There are many patients on the list who have the same MELD score who will die if they don't get a liver. So I think that's not the correct way to look at it. You have to look at the risk of drinking afterwards, and I think that's what they want to do. And I actually find that the SALT score, I mean, if you look at the positive predictive value of a high SALT score, 75% of the patients who actually are considered somebody who's high risk won't have sustained alcohol use after. And so you may actually, penalize a lot of patients based on that. I actually feel there's no substitute for having the patient come to the hospital, get to know the patients, get to know the family, have them see the addiction psychiatrist. And we've done this, and we've had patients drink after transplant in the period of time that we've been doing this. It is not an exact science, and that's why I feel it's still unfair to actually be doing this when we don't have enough data to do it. And whether or not it's chronic alcohol disease, whether or not it's 8 months they've been sober, 9 months, 1 year, I still think it doesn't make a difference. We just haven't have a good feel for who's going to drink afterwards. And to be quite honest, does it really make a difference? I mean, if a guy drinks after he gets a liver transplant for NAFL, he drinks 2 glasses of wine a week. If that doesn't impact his mortality, I don't really see that as being a problem. And there are some people who are like, we should tell all our liver transplant patients never drink alcohol after a liver transplant. And I actually kind of disagree with that.
Any other questions?
For the macitentan, so one of the common side effects is fluid retention, and I think a lot of the pulmonologists are worried to put somebody with a mean PA pressure of 46 on that. So for both our patients and in the study, did they run into problems where the side effects of fluid retention sort of outweigh the benefits? Did they treat through? What would their practice on that be?
Yeah, so the question's on macitentan. You're right, the fluid retention is an issue, and I showed the edema was, I think, 26% in the treated group versus 12% in the placebo group. They didn't specify beyond that if there were other fluid retention problems, at least in the abstract. But I personally have had a couple patients already who have had to stop macitentan because of peripheral edema. So I don't think it's not foolproof, and I'm not sure if we could figure out ahead of time which patients are going to have more trouble with it. But it's got its drawbacks, I think.
I have one last question, Todd.
Yeah.
So at your institute, do you guys ever do Tavor and transplant at the same time?
Oh, at the same time. Not that I know of. We more and more have agreed with referral for Tavor to optimize prior to transplant. I can't think of a case that had, our hope is that if they get Tavor and then they're shown to be stable and then cardiac cleared, with the idea that if there were to be complications with Tavor and they were not cardiac cleared, then unfortunately no transplant. But I haven't heard of that happening yet either. So,
okay, thank you.
In the bladder pump that you put in for the ascites, have you had problems with fluid balance and protein loss?
yes. So fluid balance, the fluid balance you can control, because when you put it in, you program how much you want it to pump. And you can pump 1 liter a day, you can pump 2 liters a day, you can pump less, you can shut it off temporarily. There's a device, like a magic wand, that you put over the pump, and it actually interfaces and you can program it. So fluid, not so much, but you have to adjust it. Protein loss, yes. I think these patients are still basically getting large volume paracenteses every week. They're just doing it in a more controlled fashion. So my patient that I put in the study, I actually had him go for albumin infusions weekly in order to, because I was seeing some kidney injury early on, so I had him going for albumin. And that's a bit of a drawback for a device. You're hoping patients won't have to go to medical care as much. But I think it's something the company's coming to terms with, that being proactive with the albumin infusions may mitigate some of the concerns with the device and the electrolytes and the hypoalbuminemia. Yeah. Earlier studies with the pump, before everyone was given antibiotic prophylaxis, there were more infections. There were pump site infections, peritonitis, UTIs. By the time the protocol, it had already been worked out in Europe. By the time the protocol came to us, everybody was required to be on antibiotic prophylaxis. So we saw fewer complications of infection. There were a few pump site infection, pocket infections. I think there were a couple of UTIs. I think one pump explant because of infection that was refractory. But by and large, the infectious complications were less than they had seen in their earlier iterations of the study.
Any other questions for the panel? Okay, so we're going to stop there. Thank you, Todd and Glenn. Those were great talks. Thank you.